Pleasure to have Soram Patel join us for this part of the program. It's my honor to be able to interview you, Soram. AstraZeneca, of course, is no stranger to the vast majority of the audience, but I'm sure they'd love to know a little bit more about what you do and a bit more about your background, and I think in particular the precision program that you're currently leading at the minute.
Brilliant, thanks Jerry, and yeah, thanks to everyone at the HITLAB team for having me today. Really excited. And yeah, so myself, I've had a slightly interesting journey. So similar to Rachel, I'm a medical doctor by background. I was trained in the UK and then was specialising in colorectal surgery, mostly in high volume cancer centres around London, but then also in New York at an East Coast paediatric trauma centre. So had fantastic experience working in that environment, operationally, quite literally. But my interest was always wandering towards how patients were actually getting to operating theatres, tables, that level of specialist care. And it was very evident that sort of when you were getting sort of treated earlier diagnosis, as we all know, often that impacts your outcomes. So when we're talking here about value-based care, that's sort of, I guess, where my journey started, because I got very much involved in quality improvement programs, looking at standards of care, and that took me on a journey sort of alongside my clinical practice, working in sort of key partnerships, basically centered on enhanced referral pathways from everywhere from Vietnam, South Africa to then involved in some large cancer centres in the UK. In increasingly, life sciences pharmaceuticals are now coming into that space because ultimately you can innovate and produce medicines, but actually if we're not improving the way access and equity in care and the outcomes, then there's a real sort of like mismatch in that space. So this is then sort of my current landing point at AstraZeneca. So I work in the respiratory department, and on a really neat program called Precision Program, we're really championing practice change. So for want of a better description, it's very much healthcare transformation and real partnerships with health systems across the globe. See, in my domain, it's respiratory, but across different conditions, how we can actually accelerate that access to medicines, treatments, generate efficiencies and pathways, and real partnerships with sort of every piece of the patient journey.
No, that's awesome. Thanks for giving us some insights to great work you're doing right now with AstraZeneca and that particular program. We've had a lot of speakers on today who are talking around about sort of costs and funding and stuff like that. With your experience, of course, with your background as a physician, I'm sure the audience would love to know about the tools and tech that healthcare providers are adopting at the minute, to sort of alleviate certain pressures around sort of trying to improve the quality of care, and how they're using that tech and those tools to ensure that patients are receiving that level care without incurring like such huge costs at the minute.
No, absolutely. Yeah, it's a really interesting space and involvement that we've come through, where there's so much of a focus on cost, both from where I mentioned like every step of the pathway, right from patients through to healthcare professionals accessing it, and then health systems can't get away from it ultimately. So where there's a vast opportunity to leverage technologies, I think that one of the previous speakers, I think Angela said, there are so many different technologies though. So where you're looking at that point of care, sort of focus on that area. And it can be really overwhelming as anyone sort of operating, whether it be healthcare professionals or also from the patient side, who is actually making the decision here, because we're moving away from that kind of like sort of a traditional previous practice that people are used to, and sort of been there through the evolution where sort of when I was taught at medical school, it was like, oh, do we even bring out phones, or is it acceptable to look at a computer during a consultation? Whereas obviously that's now massively shifted in a really short space of time, and that can really sort of like affect around a sort of patient relationship. then you've got that cost element brought into it as well. So I think from a technology perspective, we've got to be really respectful and find that sweet spot about ensuring that healthcare professional patient relationship is really kept as a sanctuary and that trust is built in. And then obviously, because on both sides, the cost part is relevant, and where we're looking at value-based care, things are also we're coming back to outcomes. So I think that warrants time and explanation. So until we get more comfortable with that is all part of someone's holistic care, that sometimes decisions are being made at that certain point for like longer term outcomes, that's how we can sort of feed it in. But I think the delivery of the technology, let's put aside like what the technology is, but how we're actually using that in those interactions, whether it be remote, in person, etc. I think that's how we can really sort of bring patients along that journey, bring also healthcare professionals along in that space where we're moving at lightning speed, quite rightly so, given these massive features that are against us. And that's a part we want to hit that sweet spot.
No, I think that's great. I think I think you really put it well with sort of taking the sort of the synergistic and holistic approach, in that sense. To sort of like change track a little bit here in terms of looking at now, from your perspective, like how existing like inequalities within healthcare, like disparities in access to care and socioeconomic differences and things like that, how is that impacting the implementation and the effectiveness of the value-based care models that you're seeing?
This is something I'm really passionate about, because there's accessing the highest quality care, and saw something really interesting, because if it was all about that, then the healthcare systems would be very straightforward and easy, right? You push out an amazing technology, the cutting edge, whatever it is, and it get adopted. Whereas actually, when we're talking amongst peers and clinicians, I think one of the analogies we often bring it back to is in those emergency scenarios, and a lot of people have very basic first aid training, so hopefully this resonates. It's always instilled to you, look for the quiet patient, someone who, there will be people that shout the loudest and it will be crying out for help, but actually it's the person that's quiet that might have the most need, is most in danger. And I often think about that when we have disparities in care and think about our value-based models. It's that patient that actually can carry the biggest disease burden in future, that could be the person that carries the most significant cost, and ultimately can actually sort of reshape your whole, or like in terms of redistribution, actually there needs to be a big and very concerted, conscious effort to consider those patients wherever they might be, and form populations. So when we're looking at, and in current practice, my current field, we're looking at how different sort of populations can access that. I mean, I mentioned before where I've worked in sort of very remote parts of Vietnam, where deliveries of healthcare provisions come every sort of third day. How can those people make sure that they get sort of the care that they need, and also to get it early critically, because where, as mentioned at the beginning, that's often part of this model. So that, again, I think we need to get comfortable with the way that principles of value-based care models might mean a redistribution in getting to the areas of greatest need. But how can we actually do that? I mean, in terms of standards, we know that in some conditions they exist, in others that they don't. In some hospitals that they do, in others that they don't. Shared learning is super important, but how we need to continue on this journey. We need to quickly get there, but also I'm a big champion of how we can sort of share those standards and best practices, not necessarily just keeping them in centers of excellence and such.
Yeah, I love that. I think with your background of having that experience in the UK as well as in the US, I'd like to sort of wrap up the conversation here, because I know we're at time, and these sessions go so quickly, and I'm sure you've got so many more insights. But just to sort of close up this conversation, we'd love to hear about some of the key factors that contribute to the divergent pop health, like you were talking about, in terms of the outcomes between the UK and the US, and how these two different countries healthcare systems and their different policies sort of play a role in shaping the, those sort of differences?
Yeah, so massively privileged to have worked in both. What I would say from a policy perspective, both countries are really trying to adopt that universal coverage. So from where the WHO says universal coverage, they're doing it, but in very different ways. And when I was working in the US, that was when the Affordable Care Act was just being implemented. So sort of very unique sense where, for example, that hadn't necessarily landed. I think one of my key takeaways was healthcare professionals, anyone working in the healthcare space, needs to have an input, needs to sort of have and need to consider how they're actually going to adopt some of these practices in person. Because, for example, I think most people could say if you walk into an emergency department and see a right arrow for one type of health insurance plan versus a left arrow for another, that's quite jarring and quite sort of different. So you can actually see just even at the front door at a point of care access how healthcare outcomes might start diversifying from that in the first instance. And I think both, US, UK, different models. I'm not here to say one's better or the other, but and I would say mine's a pediatric experience. I think there's a lot we can learn from the way we care for children, and actually sort of looking at sets of symptoms. I think Angela earlier touched on this as well, looking at sort of ecosystems, sets of patients and conditions, rather than looking at interventions and things at isolation. And that brings it back to technology as well, where we can gear things to those sorts of aspects. I mean, in terms of those two countries, I think we need to look at sort of areas. There's a big focus on bringing innovation and high costs associated with that as a limitation, but there's a huge opportunity for moving away from looking at those low value activities and redistributing that to high value add. And I think actually where healthcare technology could play a huge part in both of those healthcare systems to be able to make room for those innovations if we start doing that better. Yeah,
and I totally agree with you, Soram. Thanks so much for your coming on. We really appreciate you're busy, and you're over in the UK right now, I think. So, appreciate you coming on in the later part of the day. So many more insights I'm sure you could share, but great really being able to hear you touch upon the processes, the tech and the tools, as well as the different policies and stuff that are in place, that are trying to make this, impact in value-based care. But thanks so much for coming on. Everybody in the audience, please do connect with Soram. Her information is in the chat. And Soram, have a great rest of your evening.
Pleasure. Thanks for having me. Bye-bye.